Anybody? Where is reticular formation? It is in the brainstem. What has brainstem got? So if we look at the brainstem, what have they got? So that's the part of the brainstem. Okay, this is the midline, this is medial part, this is lateral part. Medial part and lateral part. Midbrain, pons and medulla. So what have the brainstem got normally? It has got some cranial nerve nucleus. It has got long tracts, okay, which are named. So what are the cranial nerve nucleus which are present in brainstem? So in brainstem, which are the cranial nerve present? All except first two. Okay. So before I go to the reticular formation, let me finish this first. Okay. So the in brainstem, you have got cranial nerve nucleus and long tracts. Okay. And which are named, but there are certain nucleus up to 120 or tracts which are not individually named. That is the reticular formation, which spans from the medulla, lower end of the medulla to the top of the thalamus. Okay, so that's but before that, so what are the normal cranial nerves present in the brainstem? We have said up to 3 to 12. Okay, now as Neha said 3 to 12, out of this we will divide them medially and laterally, these tracts and the nucleus. So which of these nucleus between 3 and 12 they are present medially, and which are the nucleus which are present laterally? Anyone? Which are the nucleus which are present medially, and which are the nucleus which are present laterally? Very important for exam, this part.
Lateral on side B12, elliptic, or is it
No.
4 and 4?
Multiple of 12 are present medially. So we will put all the cranial nerve on this side and long tracts on this side. So 3, 4, 6 and 12 are present medially. And which are the nucleus present laterally? All the other. Okay. Out of which one needs special mention. Which one? Fifth. The fifth. Why? What did I tell? Throughout the brainstem. Very good. So it goes and we have discussed several times what is the significance of that. Okay. So that's fifth. Clear? Cranial nerve. So the cranial nerve which are present laterally are fifth, sixth, 7, 8, 9, 10, 11. Up to this clear? Okay. Out of which only fifth sensory part is present throughout, but it has got localizing value because of the dissociation it can cause. Clear? What are the long tracts now which are present medially? What are the long tracts which are present laterally? Medially, first of all, what are the long tracts? So the pyramidal tract or the motor tract. Or what we say motor tract. What else? Medial longitudinal fasciculus. What does it do? Medial longitudinal fasciculus. What is its function? Nora, what is the function of medial longitudinal fasciculus?
I'm not sure.
It connects the third and fourth of the opposite side with the sixth cranial nerve. So come here, Nora. 1 second. You don't have to do anything. Okay. Okay, look at her eyes. What's happening? Okay, so just come here. Look at so look at this tip of the what's happening to the eyes. So if it is moved to the left, what's happening? Which cranial nerves are stimulated to cause this movement? Left abducent and right oculomotor. So how are they two talking to each other at the same time, similar movement? That's through medial longitudinal vesicle. Okay. So this talking of this third with this third, fourth with sixth, that's done by the medial longitudinal vesicle. And then there is one more tract, medial lemniscus. What does it do? We have already discussed. Yes, carry all the dorsal column sensation in the brainstem. Clear? Okay. Now, what are the tracts which are present laterally? We have already discussed about the cranial nerve. What are the tracts which are present laterally? That will all begin with S. That's the clue.
Spinal thalamic.
Spinal thalamic, that is called spinal lemniscus. What else? Spinocerebellar. Remember, the ventral one goes through the superior cerebellar peduncle, so they go all the way. And finally, another is sympathetic outflow. Okay, so these are the, so 4M are present medially, 4S are present laterally. Now, if you think, if you are given a map, how do you localize a point? In a map, you are told to localize a point, Stoke-on-Trent. How would you do? So the latitude and longitude. Okay, and you can tell exactly where a place is. Similarly, you use the same concept here. Okay, the latitudes, these are latitudes. Cranial nerve nucleuses are the latitude. Okay, and long tracts are the longitudes. Okay, so you have to use this principle. Now, what do you know? How do you know it's the latitude? Because third and fourth is present in midbrain, fifth, sixth, 7, 8 is present in pons, 9, 10, 11, 12 is present in medulla. So that's how it works as a latitude. Now the longitude is the tracts and the sensory nucleus of trigemina. Okay. And now depending on whether they are medially or laterally, you can tell as well. So what I want you, I'll give you some problem. What I want you, you have to tell me based on the problem whether it is, which part of the brainstem it is affected. One. Second, is it medial or lateral? So how would you know which part of the brainstem is affected? Via latitude. Okay, via the cranial nerve nucleus. And how would you know medial lateral? Based on both the tracts and the nucleus. Okay, now if I tell you a patient has got right third nerve palsy with left upper and lower limb weakness, where is the problem? Latitude. Which latitude it is telling you?
Which palsy was it again, sorry?
Third nerve.
So the
And weakness of the opposite side of the body.
Medial midbrain.
Medial midbrain syndrome. Okay, that's what they want in exam. A bit more difficult. Patient coming with swallowing problem. Okay, that's one. Second, they have got horn nuts on the left side. The patient has got cerebellar sign on the left side. Patient has got loss of pain and temperature on the left half of the face. But at the same time, patient has got pain and temperature and dysesthesia on the right upper and lower limb. Where is the problem?
Is it lateral medulla?
Lateral medullary syndrome. That's what they will give it. It has come consecutively in last 3 years with different problems.
Sorry, with the tracks that are on the left, what was the name of the one on? So it's the blue one on the right. Sorry, I didn't-
Sympathetic
Sympathetic.
outflow. So that's why patient can get Horner's.
Thank you.
Clear? Very important. So these are the simplified version. Apart from this tract and nucleus, there are other tracts and nucleus what we don't name individually. They are together called reticular formation. That's in the brainstem as well. Okay? So ill-defined mass of nerve cells and fiber forming an ill-defined meshwork of reticulum in the central portion of the brainstem. So they are phylogenetically old system. They are in the central part, comprises medullary, pontine and midbrain. They are polysynaptic and has got both ascending and descending component. Okay. So it's extend up to into spinal cord and also up to thalamus. So that's the extent throughout the brainstem, up to spinal cord as well as up to the thalamus. So it's a whole of this. Now, for one moment, don't think you have to remember all this nucleus. That is not possible for anyone. But what you need to know, these nucleus and tract can be divided into 3 main categories. Okay. Around the midline, so these are called median. So around the, for example, cerebral aqueduct, all these around straightly which are in the midline are the median one. Those who are just lateral to the median is called medial, and those who are lateral, they are called lateral. Okay. So median is the just the where it is in the midline itself. So these nucleus are collectively called raphe nucleus. You don't have to remember any other thing. These midline nucleus are called raphe nucleus. They secrete serotonin. They are very important in pain modulation, regulation of sleep and wake cycle, and mood regulation. Very important. Sleep, pain, and mood. And serotonin is the neurotransmitter. And as you can see, these pathway modulate pain, but these influences thalamus, hypothalamus, limbic system. They are intimately connected with this limbic system. Okay, so that's why you just need to have an overview of the limbic system. Medial one, so just lateral to the median is the medial one. So they have got big cells. Remember, they are mainly, their cells are gigantocellular. They are big cells in their median. They constitute pontine, tegmental, reticular nuclei, cuneiform and subcuneiform. So cuneiform, subcuneiform in the midbrain and pontine, tegmental. Remember, medial is concerned with motor coordination. All the autonomic motor discharge is from there. Motor control and coordination, posture and tone regulation, cardiovascular and anything with motor part of the autonomic nervous system, this part is responsible for doing that. Okay. So descending influence motor neuron in spinal cord projects to cerebellum, thalamus, contribute to motor coordination and sensory integration. So even, for example, all the motor part of the autonomic nervous system, they go through this part. So if you are doing, for example, corneal reflex, the action part is from the medial part. Okay, so they will integrate and send there from there. And the lateral part is lateral to the medial column. In the lateral part of the tegmentum, from medulla to midbrain, collectively they are made up of small cells, mainly parvocellular reticular nucleus. So they are mainly made up of small cells. They are responsible for sensory processing and integration, control visceral function, arousal and attention. Okay, remember one thing, laterally all these are more of a sensory function of the autonomic nervous system. Receive sensory information from various sources including spinal cord, cranial nerve. Ascending pathway projects to two pathways. One is going up, another is going down. Okay, influence cortex, sensory perception and consciousness, and they also go down as well to help with the. So they have got cardiac center, respiratory center, vasomotor center as a whole general, and salivatory center, chemoreceptor neurons. So afferent connection coming from spinal cord via spino-reticular tract and collateral from ascending tract, brainstem afferent from cranial nerve including vestibular, and tectoreticular from tectum, inferior colliculus and superior colliculus. And afferent connection also come from cerebellum, basal ganglion, neocortex. So that's again the part of the limbic system, and limbic lobe including amygdala and hippocampus, the subcortical part of the limbic system. So they are heavily connected to the limbic system, cerebellum and basal ganglia. And they go to spinal cord and brainstem. So they go to spinal cord, descending reticulospinal tract, and which connects to the, remember, descending sphere, which is connecting, out of which there is a pontine component and the medullary component. We told medullary reticulospinal tract, pontine reticulospinal tract. And reticular bulbar fiber connects to the cranial motor. So it goes up and down. So efferent connection, where are they descending efferent? To the cerebellum, to the red nucleus, substantia nigra, tectum, to the thalamus, subthalamic, hypothalamus, to the basal ganglion, neocortex, limbic lobe, indirectly through thalamus and hypothalamus. So it's again the same pathway. But one is the raphe, which is pain modulation, sleep-wake cycle, and affect your mood. And then the medial part is with motor, lateral part is sensory. All the visceral sensory information. That's what their main function is. On the basis of this ascending and descending reticular. So ascending system, descending system, we have already discussed. So the main last part of this is role in sleep and wakefulness. Okay, if this part is damaged, patient can completely lose, because they might not wake up. Okay. Responsible for alerting response to emotional and the muscular what? Control muscle tone, influence endocrine secretion through hypothalamus, role in visceral function, influence circadian rhythm, influence EEG and learning process, modulate afferent transmission, influences autonomic nervous system. So you don't have to remember all these things, but you can understand what are the parts. It is connecting through the limbic system and causing all the effect. Okay. So that's, I think you don't need to know all these things. But one of the other function is the eye control, eye movement control for reticular formation. So where is the center for controlling the eye movement? For horizontal eye movement, for so PPRF is for horizontal. What about up and down? It's again in the reticular formation. It would be the interstitial of Cajal. Okay. And where will be this nucleus, medially or laterally? If they are doing a motor movement, medial. Okay, so that's the pattern is simple. So they coordinate. Where will they receive information from? From the, so for example, Daniel, come here. sit over here. So if there is a saccadic movement, okay, look at my finger where it is snapping. So this is fast movement. Where is the pathway? So this information has to go from the ear. If I've said and also vision, it will go to the frontal eye field. Okay, frontal eye field in the frontal lobe, which will cross, the fiber will go down, which will cross the midline and come to the PPRF, paramedian pontine reticular formation. Okay, and that will stimulate the same sided sixth and opposite sided third to cause the movement on particular direction. Is that okay? Now see this movement. What is this movement? This is called Patsu movement, where you are following a target slowly. This reflex is quite complicated. Okay, so where does it start? Obviously, it's come to the visual cortex. Then in the temporo-parieto-occipital junction it starts. That's the center for the Patsu area. It goes to the frontal eye field. Then it will go down on the same side, go to the cerebellum. Okay, from cerebellum it will come to the vestibular nucleus and come back to the same sided PPRF. So if I draw it, it will be clearer. So you are when you are doing a Patsu movement, so this is the midline, this is right, and this is left. If your left side PPRF center is situated, which is in the temporo-parieto-occipital junction, okay, so that will send information to the same sided where this saccadic area is, okay, prefrontal cortex. From there, the information will go to the same sided cerebellum. Okay, from the cerebellum it will go to the vestibular nucleus on the opposite side, and from there it will come to the PPRF. So eventually it is controlling the same side, whereas in the saccade it was the opposite side. Okay, so it goes to the cerebellum, come back to the PPRF and cause the movement. Now there is another movement. Okay. You look now. Just keep your. Can somebody else? Why don't you come? Just hold a finger here and see what is happening to his eyes. Just keep. So what's happening to the eye when it is moved to the left? What's happening to his eye? Now what did the right eyeball? If I am moving to the left, what's happening to the eyeball? Moving to the right. So if I am moving to the left, it's moving to the right. The eyeball is, what is this called? Vestibulo-ocular reflex. So why this is happening? So when it is stimulating, when it's just keep. So when it is moved, this vestibular nucleus is stimulated. What will it do? It will cross and supply the opposite sided PPRF, which will stimulate this sided sixth. That's why the eyeball is moving to this side, and through the medial longitudinal fasciculus is supplying the third of the opposite side to cause the eye to move, the other eye to move. So this is the vestibulo-ocular reflex. One more. Can you stop this vestibulo-ocular reflex? See, I'll show it can be stopped because he has got a brainstem which is intact, I'm sure. Sit here. you keep your leg up so that I can swing the, okay, keep your hands straight like this, okay, and now look at his eyes, okay. Normally, if it is, now first of all see what's happening, just keep it like that. What's happening to the eyes? Just you look straight ahead. What's happening to his eyes? Moving. Now keep your hands up like this. Just focus over here and now see what's happening to his eyes. Not moving. VOR is cancelled. This is done by the cerebellum. Okay. So cerebellum can overpower VOR and cancel it. But what happens if there is a brainstem stroke? The cerebellar pathway won't communicate. So then when you are trying to do it, the eyeball will move, and that will give you a clue that this patient has got central cause. Okay. So these are the eye movements. So these eye movements, reticular formation has got an important role, as you can see. Okay, very good. Thank you. That's all about reticular formation. There are various neurotransmitter in different, but I'm not going into that. But this, if you know, that's more than enough.